Welcome to Chapter 22, Abdominal Emergencies. This chapter we're going to talk about the different medical emergencies with the abdomen. The one thing to remember with these ones, the abdomen is kind of a complex issue, so not getting caught up in diagnosis when it comes to specific issues in the field, but understanding all these components so that you can make a diagnosis as related to a test question. So we're going to kind of review some of the anatomy and physiology that goes along with it, and some organ placement and so on. The abdomen can create quite a bit of confusion when it comes to specific abdominal emergencies. Your patient assessment is absolutely paramount in this circumstance, asking questions. The abdomen is one of those places where people have a little bit of reservance when it comes to wanting to place their hands on patients. Just don't forget that the patient assessment, the hands-on assessment in this circumstance is going to be vitally important. We don't normally or typically do bowel sounds and things along those lines, but let's not forget there's not a very big difference in space when it comes to your chest cavity and your abdominal cavity, so therefore making sure that there's not a possibility that it's a chest problem that's causing the abdominal problem or vice versa. So a real good, thorough patient assessment is going to be absolutely critical. So the abdomen is that region between the diaphragm and the pelvis. It's got lots of organs that deal with a couple different systems, so definitely a lot of problems can be traced back to the possibility of an abdominal issue. So here's a look at the different organs. This is definitely something you want to have a pretty good grasp on when it comes to the placement of organs. We have 4 quadrants in our body that intersect at the belly button. I'm going to attempt to do this here. A real rough attempt at it. But those quadrants intersect, roughly about right there. And so just having kind of an idea what lies in what quadrant is going to be extremely important. Just don't forget that the big confusing thing that people have a tendency to do, it's a pretty common mistake, is this side over here, even though we're looking at it, this is the right hand side of the patient, this is the left hand side of the patient. So this is the right upper, this is the left upper, and so on. So just having a pretty good idea. Your liver and your pancreas take up 2 quadrants. Your intestines take up 4 quadrants in a lot of circumstances. In fact, this one's a little bit low down here. So probably better off removing this one. I don't know how to do that. So can kind of get rid of this one. But your intestines take up quadrants. Have an idea where your gallbladder is, where your appendix is. Things along those lines can be pretty important working our way through it. So this is again another look, and kind of do the same thing here. When it comes to quadrants, these are the different organs and their basic functions. The appendix says no function, depending on the literature that you read. There's definitely some talk about its actual function and so on, but this is just real basic, not getting into a lot of advanced anatomy and physiology or anything along those lines. Again, we talked about the abdomen divided up into 4 quadrants. That right upper, left upper, right lower, and left lower. Here's just kind of a visual look at that as well. If you look at this is a much better drawing than I attempted here a moment ago. So anatomy and physiology wise, couple of definitions, and these definitions can be a little bit confusing for people. These are really good flashcard options as well. Organs of the abdomen, we got the peritoneum, which is this thin membrane lining the abdominal cavity and covering each organ. I got a diagram coming up to kind of talk about that. The parietal peritoneum is attached to the abdominal wall, where the visceral peritoneum covers each organ. So as you can see here, we took the broad term peritoneum and we gave you a couple of specifics here. So the parietal peritoneum is attached to the abdominal wall, and the visceral peritoneum covers each individual organ. For the most part, most of the organs of the abdomen are enclosed within that parietal peritoneum. We have a couple that lie in the extraperitoneal cavity or outside that peritoneum. Like I said, I got a diagram coming up here, and we'll just kind of go to that. So what we're looking at here, the blue, actually see the coloring here. The lining that runs along this is going to be that parietal peritoneum. Visceral, again, is going to cover each individual organ, but you have these organs that lie outside of that. So obviously your kidneys lie in that retroperitoneal cavity. This is also a really good look when we talked about abdominal aortic aneurysms. This is your aorta that runs down here. So you can kind of see how that referred back pain is fairly common, where we don't necessarily always get that stomach pain. Abdominal pain and discomfort, again, related to that, we got visceral pain and we got parietal pain. Visceral pain, because it originates from the visceral peritoneal cavity, this is going to be originating from the organs itself. There's not a lot of nerve endings that allow for diffuse sensations, or they only allow for diffuse sensations. So a lot of patients will describe this as dull or achy. The way I remember it is they almost always use their open hand. As you can see, I'm the world's worst artist, but they will use their hand over their stomach to describe where that pain is, because it's real broad and not very specific. It's not uncommon to have that colic or that intermittent pain that comes and goes and in waves, and we're going to talk about that patient assessment here shortly. The parietal pain, this is from that the parietal peritoneum. So this has got quite a few nerve endings that allow for specific and efficient sensations of pain. A lot of patients will describe this as sharp. Most of the time, it's a pretty consistent pain localized to one specific area, and patients usually describe this with one finger. They'll point directly to one location that says their abdominal pain is in this area. Tearing pain, again, we talked about this with the abdominal aortic area. Tearing pain, most common type of abdominal pain. This is going to be originating in the aorta. I'd like you to associate the word tearing with this fact right here, and the fact that if your patient complains of tearing-like pain, that you definitely have a high index of suspicion for the possibility of aortic involvement. Referred pain, this is a little bit confusing because it is very similar to radiating pain. Radiating pain is pain that moves to other locations of the body, where referred pain is because of the nerve pathways, it's actually being picked up, the sensation is being picked up at a different location. So it's not uncommon to have gallstones that refer pain to the left-hand shoulder. Appendicitis has a tendency to refer to the belly button area. So all those things are a possibility. So when you're asking those OPQ or ST questions, don't forget to narrow in as if this is a referred pain or is it the possibility of a pain in actually a separate location. So we're going to talk about specific abdominal conditions. One of the first ones we're going to talk about, also fairly common, is appendicitis. Appendicitis, people have kind of a hard time with this one. I get a little bit confused. This suffix right here means inflammation or swelling. So when we're talking about appendicitis, we're not talking about an appendix that has ruptured. We're just talking about the swelling that's leading up to that. So it's the infection of the appendix. With infection normally comes temperature and fevers. So nausea, vomiting, fever, whether it's low grade, all those things should be red flags. Pain, that's often, it can be referred to the umbilical area. The biggest one is right lower quadrant pain. Should be a pretty good indication that we're dealing with appendicitis. The other one that's unique to appendicitis is they complain of rebound tenderness, which means when you palpate, like I said, using your hands, when you push down, it actually decreases the amount of pain, as to where when you let up, it actually has an increase of pain. So we call that rebound tenderness. Is also a big red flag when it comes to appendicitis. When the appendix eventually ruptures, if it does, there's a sudden severe increase in pain, and then as those contents release into the abdomen, it causes pretty severe what's called peritonitis, which again, if you break this down, we're talking about the inflammation or the swelling of the peritoneal cavity. This can cause high fevers, and cause some pretty substantial issues. The other piece with that, with peritonitis, so we're kind of just piggybacking off what we were talking about, this irritation actually causes involuntary muscle contraction and causes substantial amounts of pain. The patients that complain of these muscle contractions, a lot of them like or prefer that left lateral position with their knees drawn up to their chest. That actually decreases the amount of pull that's being pulled on those abdominal muscles. Cholecystitis or gallstones. Again, that itis word, you're seeing that inflammation quite a bit. This is inflammation of the gallbladder. Most of the time it's often caused this cholecystolithiasis. I probably didn't pronounce that correct, but lith means stone, so that's a gallstone that's actually blocked the outlet. Red flags for this, the big ones, right upper quadrant or epigastric pain. It's common this either refers to the right or the left shoulder, as well as patients complain that they have an increase of pain while eating fatty foods. So again, in order to, you know this now, so in order to actually pick up on that, you're going to have to ask those questions. Pancreatitis, most of the times that we see this, we're seeing this in our diabetic patients. Alcohol abuse patients is very common to see this, as well as when it comes to the cancers of the pancreas. Again, notice this suffix again, itis, meaning inflammation of something. In this case, it's the pancreas. Signs and symptoms, epigastric pain. Again, that's real high abdominal pain. If you go back to that diagram, you remember that your pancreas sits real high up in the right and left quadrant pains. Right and left quadrant. The pain can be in either one of those or both. A lot of times it gets referred to the back or to the shoulders. With that patient assessment piece, as I said, you've got to assess the abdomen and so on. Kind of some tricks of the trade. Definitely one of them is you're never going to feel an organ that is swollen unless you know what a normal sized organ feels like. And the only way you know what normal sized organs feel like is by palpating abdomens. So be real diligent when it comes to practicing palpation, feeling, actually understanding and remembering what those feel like, as well as in the circumstances. If they're complaining of pain in one specific area, then you want to start your palpation the opposite and work your way to it. You don't want to palpate that sore quadrant first. A couple other problems we're going to talk about. GI bleeding, which is a hemorrhage within that lumen of the GI tract, so inside that tube itself. This can range anywhere from severe bleeding to minor bleeding. The blood eventually, when it builds up in the GI system, has to exit either out of the mouth or the rectum. A lot of times these patients don't have any pain associated with it. This can be extremely life-threatening. It can cause enough bleeding to cause hypotension and shock and possibly death. The downfall is there's nothing we can do to treat it except for rapid transport. So asking questions, some of the not fun questions is they're talking about diarrhea. You asking questions about was there blood? What did it look like? They're talking about vomiting. Again, what did it look like? Was there any presence of blood? Because again, there may not be any pain associated with this. Abdominal aortic aneurysms. You remember that picture where it talked about the location of the aorta. This is a ballooning or weakening of that inner wall of the aorta itself. So what happens is it tears and separates from the outer layers. So it actually creates a balloon or a ball on the aorta. That tearing sensation is where they feel those layers actually being pulled apart. Now with this, pain is about the only signs and symptom. You may not get any change in vital signs, except for maybe an absent in pulse or a decrease in pulse on the extremities, the lower extremities, from right leg to left leg or vice versa. So you might have a strong pulse in the left leg, but an absent or weak pulse on the right-hand side. That should be a pretty good red flag. You could be dealing with this aortic dissection. You'll normally hear us refer to this as a triple A. We're just referring to A, and A. And we're talking about that. It's the abdominal aortic aneurysm. What happens is that balloon gets bigger and bigger, and what eventually happens is that ruptures. The downfall of that rupture is it's most likely a fatal hemorrhage that kills people. It's a lot of blood flow going, a lot of pressure, and it is an artery, so therefore when it ruptures, it causes pretty substantial blood loss. So here's your signs and symptoms. Definitely something you want to be aggressive when it comes to diagnosing as well as transporting as quick as possible. It's kind of a progressive pain. It starts out as sharp, works its way into tearing. It's usually radiated to the back, sometimes to the abdomen. One of the things, again, there's that word palpate. So when you palpate the abdomen, it's in the middle, right? Because your aorta sits in the middle. You actually have a palpable mass that could be pulsating. It would be pulsating with a heart rate. The reason why we talk about a pulsating mass is this is how you determine that it's not a hernia. A hernia feels very, very similar in the fact that it's a palpable mass in the abdomen, but hernias don't pulsate because normally we're talking about intestines that are being pushed through the lining of the, or between the muscles. So therefore, there's kind of the ways that you try to diagnose. Are we talking about a AAA, or is this the possibility of a hernia? Again, sudden severe increase in pain may indicate a rupture. A lot of times we're dealing with that fatal hemorrhage, so therefore these patients don't have a very high percent of positive outcome. Here we're talking about the hernias. Again, very similar in the presentation, except for the fact that it's not pulsating. But this is a hole in the muscle layer of the abdominal wall. It allows the tissues, most commonly it's the intestines, that protrude up against the skin. Heavy lifting, strenuous effort, something along those lines is pretty common to have a hernia. What we don't want is it can cause some strangulation of the tissue, or that actually cause a bowel obstruction. A lot of times these require surgical repairs. Sometimes after surgeries or something along those lines, they decide to leave those things in place and don't surgically remove them. Signs and symptoms: sudden onset of abdominal pain, often following exertion. Again, we talked about the palpable mass or lump on the abdominal wall, or the crease of the groin is also fairly common. We refer to those as the inguinal hernias. Renal colic, so this is pretty common when it comes to flank pain. Kidney stones is a fairly common thing, but what it is those kidney stones are traveling down the ureter. Severe pain, cramping pain, intermittent pain here and there. Sometimes it's relieved with walking around. Sometimes it's a persistent pain. A lot of times it's referred to the groin. Presence of nausea and vomiting is also fairly common. Cardiac involvement: anytime you're dealing with the term epigastric pain, associate that with being pretty high up in the abdomen. Therefore, there's the possibility of that cardiac involvement, such as a myocardial infarction or a heart attack. So don't get caught up in the fact that it presents with abdominal pain that you don't think it's cardiac related. So just kind of be aware that they can present similar. Anytime the patient complains that epigastric or that indigestion, heartburn, pain, make sure to put MI or heart attack on your differential diagnosis list. So assessment: these are just kind of like the things we were talking about, the rules of thumb. Many potential causes of abdominal pain. So in the field, it's not our job to diagnose one specifically. Most of our treatments are the same when it comes to position of comfort, watching for airway, breathing, circulation problems like signs of shock or airway obstructions. But really our job is just to focus on a real good thorough assessment, make sure there's not life-threatening problems, ensure that they're getting good oxygenation, there's no airway problems, and transport them as quick as possible. Seeing size-up issues: we always be worried about bloodborne pathogens when it comes to these patients. Odors is also common when it comes to GI bleeds. They have a pretty pungent smell, so just kind of being aware of that and protecting yourself. If the patient's vomiting, be thinking about eye protection as well as face protection. All those things we kind of talked about, the bloodborne pathogens. Patient assessment: nothing really changes here. General impression, ABCs, level of consciousness, all these things are important. Your OPQRST questions, it's the same. What were you doing when this started? What makes it better or worse? Does moving make it worse? Does your position, does it feel better on your right side or your left side? Quality: can you describe that sensation? Again, is it sharp? Is it stabbing? Not that you're giving them those words to state, but you're asking those questions and you're looking for those red flags. Radiation: can you point to where it's at? Again, pay attention. Are they pointing with one hand, or are they pointing with an open hand? Does that pain radiate? Does it move? On a scale of 1 to 10, 1 being no pain, 10 being the very worst pain in your life. Where's your pain sitting at? Time: do you have pain all the time? Is it intermittent? Has it changed? All those things are questions you definitely want to ask. History specific to your female patients, because of the fact of abdominal pain can be a pregnancy-related problem. You want to ask questions about their menstrual cycle. Where are they at when it comes to, is your period late? Is there any chance that you could be pregnant? Asking questions about, any history of heavy bleeding. Have you ever had this pain before? Some of these patients might have pain with their menstrual cycles on a regular basis, so asking those questions is pretty important. Are you using birth control? In certain circumstances, asking if they're sexually active could be in your questioning, due to the fact that this could be whether it's pregnancy related or STD related. Those questions are questions that we're going to have to ask our patients to determine as much as possible, so we can make a good assessment as well as a good diagnosis. Past medical history, nothing really changes here when it comes to sample. Geriatric note, we're going to talk more about geriatrics in the coming chapters, but definitely understanding that they don't have that ability to perceive pain as well as we do. So there might be a pretty serious cause of abdominal pain that we're missing because of the fact that they're not complaining of severe abdominal pain. So ask questions and make sure that make sure that it's not something a little more life-threatening that's just being covered up. Physical inspection, again, there's three things that we're going to have here. There's inspect, there is, two things, inspect and palpate, because we're not going to auscultate in these circumstances. When it comes to inspection, inspection means you have to use your eyes. And I will tell you this is important, and it seems kind of silly that I'm attempting to write this word in a pen, but if the patient has a shirt over their abdomen, that doesn't count as inspection. You've got to lift that shirt up and look for distension, which would mean, increase in size. Discoloration, which would mean, is it purple, is it red, is there bruising, and then protrusions. Is it visibly obvious they have something protruding underneath the skin? All those things sometimes can get covered up with clothing, so make sure that you use your eyes. And then, of course, palpate means you have to place your hands on patients and you have to actually assess them. We talked about palpating the painful area last, and then you want to use your fingertips, and the things you're looking for is rigidity, which would be muscle, something along those lines. Pain, which of course we know what that means, and guarding is an involuntary muscle contraction when you push on it. So your muscles are real contracted trying to protect those organs. Vital signs, if you deem them to be critical, then you want to have a baseline vitals you want to take baseline, and then you want to repeat vitals every 5 minutes. Pulse, respirations, blood pressure, skin CTC, again that's color, temperature, and condition, is important. Pulse ox, mental status, making sure you're getting blood glucose, because again we're dealing with the possibility of pancreas involvement here. All those things are going to be important when it comes to vital signs. The other one I would add to this, of course, is your temperature and the fact that you want to know if we're dealing with any kind of the possibility of infection. General abdominal distress, again, patients complain of nausea or vomiting. You may not deem them to be critical, but these are the patients you don't want to give them anything by mouth. You want to make sure they have an intact airway at all times, because vomiting can increase airway problems. Understand that discomfort is a possibility, pain is a possibility. So just make sure you address those things. Again, position of comfort is going to be horribly important for these patients. The other one is I would have some sort of bio emesis bag or puke bag available to them, so that way they're not trying to look for something to vomit in, and that could cause some aspiration. Patient care, we kind of talked about this. Maintaining the airway, maintaining the oxygenation is important. Their position and comfort, a lot of patients like that left lateral recumbent position, or laying on their left-hand side, and then you're going to transport to them the appropriate facility. All right, that's the end of the chapter. Like always, you got any questions, you can put them over there in the question category for TED Ed.